Hello everyone, my name is Kimberly and today we will be discussing anti-inflammatory, anti-allergic, and immunologic drugs together with my partner, Bebeline.
Hi, I am Babylene. For our topic outline, we will be discussing review of immune system, childhood immunization, immunodepressants, antihistamine, cyclooxygenase inhibitors, non-steroidal anti-inflammatory drugs, and acetaminophen, and glucocorticoids and non-endocrine disorders.
Without further ado, let me first discuss the review of the immune system. So we know that we have two types of immune response, the natural immunity or the innate or native immunity and the specific acquired immunity. So the specific acquired immune responses can be classified as either cell-mediated or humoral. Cell-mediated immunity refers to the immune responses in which targets are attacked directly by the immune system cells, specifically the cytolytic T cells and the macrophages. While the humoral immunity refers to the immune responses that are mediated by antibodies. So, immune responses are mediated by several types of cells, some of which play a bigger role than others. The major actors are the lymphocytes, or the B cells, cytolytic T cells, helper T cells, macrophages, and dendritic cells. Accessory cells include neutrophils and basophils. So B cells have the job of making antibodies. Hence, B cells mediate humoral immunity. Cytolytic T lymphocytes or cytolytic T cells or CD8 cells are key players in cellular immunity. These cells do not produce antibodies, rather they attack and kill target cells directly. Next is the helper T lymphocytes or the helper T cells or CD4 cells. Helper T cells contribute to the immune system in three ways. They have an essential role in the antibody production by B cells. They release factors that promote type 4 sensitivity reactions, also known as the delayed type hypersensitivity, and they participate in the activation of cytolytic T cells. Next is the macrophages. Macrophages begin their existence in the bone marrow, enter the blood as monocytes, and then infiltrate tissues where they evolve into macrophages. Macrophages are present in all organs and tissues. Next is the dendritic cells. Dendritic cells perform the same antigen-presenting task as do macrophages. However, unlike macrophages, dendritic cells do not also serve as scavengers. Dendritic cells are found in lymph nodes and other lymphoid tissues. Mast cells and basophils. These cells mediate immediate hypersensitivity reactions. Mast cells, which are derived from basophils, are concentrated in the skin and other soft tissues. Basophils circulate in the blood. Both cell types release histamine, heparin, and other compounds that cause the symptoms of immediate hypersensitivity. Next is neutrophils, also known as polymorphonuclear leukocytes. Phagocytize bacteria and other foreign particles. And lastly is the eosinophils. Eosinophils attack and destroy foreign particles that have been coated with antibodies of immunoglobulin E or IgE class. The usual target is helminths or the parasitic worms. Antibodies. What are those? They have the ability to recognize and bind with specific antigens. Alternative names for antibodies are immunoglobulins and gamma globulins. Antigens. It is the molecules that induce specific immune responses and, as a result, becomes the target of those responses. For the characteristic features of immune responses, they share 5 characteristic features: the specificity, diversity, memory, time limitation, and selectivity. And for antigens of non-self origin. For the specificity, cell-mediated and humoral immune response are triggered by specific antigens, and their purpose is to destroy the antigen that triggered the response. For the diversity, our immune systems can respond to millions of different antigenic terminants. For memory, Exposure to antigen affects the immune system such that re-exposure produces a faster, larger, and a more prolonged response compared with the initial exposure. For time limitation, immune responses don't last indefinitely. They are time limited. The reasons are twofold. First, as the immune response proceeds, it greatly decreases the level of antigen that initiated the response, thereby attenuating the stimulus for continuing. And lastly, for the selectivity for antigens of non-self origin. Under normal conditions or in immune systems that target only foreign antigens, leaving potentially antigenic molecules in our own cells untouched. So for the phases of the immune response can be viewed as having three main phases: the recognition, activation, and effector phase. For the recognition phase occurs when a mature lymphocyte encounters its matching antigen. All specific immune responses begin with antigen recognition by B cells and T cells. For the activation phase, it activates the lymphocyte, which then undergoes proliferation and differentiation. Some of the daughter cells differentiate into cells that actively participate in the immune response, attacking the source of the antigen. And lastly, the effector phase. In this stage, the immune system attempts to eliminate the specific antigen that initiated the response. With cell-mediated or antibody-mediated immunity, several effector mechanisms can be involved. For the cytokines, lymphokines, and monokines, the terms cytokine, lymphokine, and monokine are encountered frequently when discussing the immune system and can be a source of confusion. The term cytokine refers to any mediator molecule other than an antibody released by any immune system cell. A lymphokine is simply a cytokine released by a lymphocyte, and a monokine is simply a cytokine released by a mononuclear phagocyte. Put another way, cytokine is a generic term for the whole class of non-antibody mediators released by immune cells, whereas the terms lymphokine and monokine are more restrictive, referring only to non-antibody mediators released by lymphocytes and mononuclear phagocytes, respectively. So as noted, there are two types of immune responses: the humoral immunity and the cell-mediated immunity. In this section, we review humoral immunity, focusing on how antibodies are produced and the mechanisms by which antibodies protect us. So production of antibodies, we have first the overview of antibody production. So the production of antibodies begins with the binding of specific antigen to two types of cells: a virgin B cell and an APC. The APC may be either a macrophage or a dendritic cell. For the specific cellular events in antibody production, we have first the B cells. The participation of B cells in the immune response begins with recognition and binding of specific antigen. The receptor that B cells employ for antigen recognition is actually an antibody. For the antigen-presenting cells, or the APCs, it is essential for activation of CD4 helper T cells because CD4 cells cannot recognize antigen that is free in solution. Rather, they can only recognize the antigen that has been complexed with an MHC2 molecule. And lastly, the helper T cells are the CD4 cells. The job of CD4 cells in humoral immunity is to activate B cells. In the absence of activation by CD4 cells, B cells are unable to proliferate and produce antibodies. For the cell-mediated immunity, it has two branches, one mediated by helper T lymphocytes, or CD4 cells plus macrophages, and one mediated primarily by cytolytic T lymphocytes, or CD8 cells. In this branch mediated by CD4 cells and macrophages, the result is called delayed-type hypersensitivity. In the branch mediated by CD8 cells, the result is target cell lysis. So for the delayed-type hypersensitivity, first we have the activation of helper T cells. Activation of CD4 cells in DTH is essentially identical to the activation of CD4 cells in humoral immunity. Next is the activation of macrophages. So interferon gamma released from the activated CD4 cell is the major stimulus for macrophage activation. In response to interferon gamma, macrophages increase production of lysosomes and reactive oxygen. So So for cytolytic T lymphocytes, first activation of it requires the participation of antigen-presenting cell and a helper T cell. The process is very similar to the activation of CD4 cells already discussed. So for next is the recognition of virally infected target cells. It is when CTLs recognize their targets by the presence of antigen MHC-I complex. This is the same process by which CTLs recognizes APCs. And lastly, the mechanisms of cell kill. Binding of a CTL to its target cell causes the CTL to release mediators that kill the target. Two mechanisms of cell kill are involved: lysis and apoptosis, programmed cell death. So in summary of this review of immune system, the immune system helps us by attacking invading organisms or the viruses, bacteria, fungi, and parasites, and cancer cells. The immune system can hurt us by attacking transplants and their own healthy cells. So there are two types of specific acquired immunity: the cell-mediated immunity and the antibody-mediated immunity. And there are also two basic types of immune responses: the natural immunity and the specific acquired immunity. Again, B cells make antibodies and the CTLs kill target cells directly. So we are now in the part 2 of our topic. It is the childhood immunizations. But first, let us define the terminologies. Vaccine is a preparation containing whole or fractionated microorganisms. Killed vaccines versus live vaccines, those are the two major classes of vaccine. So killed vaccines are composed of the whole killed microbes or isolated microbial components. In contrast, live attenuated vaccines are composed of live microbes that have been weakened or rendered completely avirulent. Vaccination refers broadly to giving any vaccine or toxoid, or the production of the active immunity. Toxoid is a bacterial toxin that has been changed to a non-toxic form. Administration causes the recipient's immune system to manufacture antitoxins. Immunization is a production of both active immunity and passive immunity. So active immunity has a response to infection or to administration of a vaccine or toxoid. Lastly, passive immunity is by giving a patient preformed antibodies, protects immediately, but persists only as long as the antibodies remain in the body. So for the public health impact of immunization, immunization saves lives. It protects you, your family, and your community. Immunization helps future generations by eradicating diseases. And many infectious diseases are rare or eradicated now as a result of immunization programs, but new infectious diseases are preparing around the world. So reporting vaccine preventable diseases. Each week, the state health departments make a report to the Centers for Disease Control and Prevention, or the CDC. The information is used to determine if an outbreak is occurring, to evaluate prevention and control strategies, and evaluate the impact of national immunization policies and practices. For the immunization records, the National Childhood Vaccine Injury Act of 1986 requires a permanent record of each mandated vaccination a child receives. So the following data are required: date of vaccination, route and site of vaccination, vaccine type, manufacturer, lot number and expiration date, name, address, and the title of the person administering the vaccine. For the adverse effects of immunizations, vaccines are generally very safe. Although mild reactions are common, serious events are rare. Many children experience local reactions such as discomfort, swelling, and erythema at the injection site. Fever is also common, very rare, but severe effects include anaphylaxis, acute encephalopathy, and vaccine-associated paralytic poliomyelitis caused by the oral poliovirus vaccine.
Now we will tackle the target diseases. So the routine childhood vaccination is currently recommended for the protection against 16 infectious diseases such as diphtheria, tetanus or laxo, pertussis or whooping cough, measles, mumps, rubella, invasive H, influenza type B, hepatitis A, hepatitis B, polio, varicella chickenpox, influenza, invasive pneumococcal disease, meningococcal disease or meningitis, rotavirus, gastroenteritis, and genital human papillomavirus infection. In the discussion below, certain VPDS are considered in a group such as measles, mumps, and rubella because vaccination against these VPDs is traditionally done simultaneously using a combination vaccine. First, we have the measles, mumps, and rubella as seen in the PowerPoint presentation. For the measles is a highly contagious viral disease characterized by rash and high fever. Infection is spread by inhalation of aerosolized sputum or by direct contact with nasal or throat secretions. Mumps is a viral disease that primarily affects the parotid glands, or the largest of the three pairs of salivary glands. It usually occurs in the children ages 5 to 15. As a rule, the first symptom is swelling in one of the parotid glands, often accompanied by local pain and tenderness. And lastly, rubella, also known as German measles, it is generally mild viral infection. However, if it occurs during pregnancy, the consequences can be severe. Initial symptoms include sore throat, mild fever, and swelling in lymph nodes located behind the ears and in the back of the neck. So for the efficacy, following a single dose of MMR, an effective response develops in 97% of vaccinated patients within 2 to 6 weeks. A second dose increases protection. So for the adverse effects, we have mild and severe. For mild, local soreness, erythema, and swelling may develop soon after vaccination. For the severe, transient thrombocytopenia occurs very rarely. For the route, site, and schedule of immunization, we have the subcutaneous or the outer of upper arm. We have 2 vaccinations. First dose is the 12 to 15 months, while the second dose is between 4 to 6 years old. Precautions and contraindications. MMR is contraindicated during pregnancy and should be used with caution in children with a history of thrombocytopenia or thrombocytopenic purpura or anaphylactic-like reactions to gelatin or neomycin, because MMR contains a small amount of this antibiotic. Next is diphtheria, tetanus, and pertussis. Diphtheria is a potentially fatal infection caused by Corynebacterium diphtheriae, a gram-positive bacillus body. Initial symptoms include sore throat, fever, headache, and nausea. Tetanus or lockjaw is a frequently fatal disease characterized by painful spasm of all skeletal muscles. The first symptom is often stiffness of the jaw. As infection progresses, the patient may experience stiff neck, difficulty swallowing, restlessness, irritability, headache, chills, fever, and convulsions. Pertussis or the whooping cough, or the 100-day cough, occurs primarily in infants and young children. Initial symptoms include rhinorrhea, mild fever, and persistent cough. As infection worsens, coughing becomes more intense. For the efficacy, immunization with DCAP reduces the risk of disease by 80% to 90%. Protection begins after the third dose and persists 4 to 6 years against pertussis and 10 years against diphtheria and tetanus. Adverse effects is mild, moderate, and severe. So for mild reactions are common. The reactions seen most often are low fever, fretfulness, drowsiness, anorexia, and local reactions such as pain, swelling, and redness. Moderate effects occur less often than mild reactions. Persistent, inconsolable crying lasting 3 hours or longer occurs in 1% of vaccinated patients. And lastly, the severe effects or the encephalopathy. Very rarely, DTaP causes acute encephalopathy. This incidence is between 0 and 10.5 episodes per million doses. Most cases occur within 3 days of vaccination. Next is the precautions and contraindications. It can be administered to children with mild febrile illness. However, for children with moderate or severe febrile illness, administration should be postponed until the illness has resolved. For its route, site, and schedule of immunization, it is injected intramuscular into the deltoid muscle or thigh. Routine vaccination consists of 5 injections, the first at 2 months, the second at 4 months, the third at 6 months, the fourth between 15 to 18 months, and the fifth between 4 to 6 years. After the initial series, all children should receive a booster shot of TD every 10 years. Next is the poliomyelitis. Also known as polio or infantile paralysis, is a serious disease in which the poliovirus attacks neurons of the central nervous system that control muscle movement. The result is a skeletal muscle paralysis, usually in the legs. For efficacy, between 97.5% and 100% of children receiving IPV develop antibodies to poliovirus types 1, 2, and 3. Antibodies develop after 2 or more doses and persist for many years. For adverse effects, IPV is devoid of serious adverse effects. As with other injected drugs, local soreness may occur. So for its route, site, and schedule of immunization, subcutaneous, the anterolateral tie. 4 doses, the first at 2 months, the second at 4 months, the third between 6 and 18 months, and the fourth between 4 to 6 years old. Next, we have the Haemophilus influenzae type B. It is a gram-negative bacterium that can cause meningitis, pneumonia, and serious throat and ear infections. Its efficacy by 88% to 98%. When Fedvax HIV is used, protection begins 1 week after the first dose. However, when HIV is used, protection is delayed, beginning 1 to 2 weeks after the fourth dose. With both vaccines, protection persists for several years. Preparations: vaccines directed against H. influenzae type B are prepared by conjugating a purified capsular polysaccharide from H. influenzae to either tetanus toxoid or an outer membrane protein, isolated from Neisseria meningitidis. So its adverse effects is among the safest of all vaccines. Serious adverse effects have not been reported. The few adverse effects that do occur are generally transient and mild. For its route, site, and schedule of immunization, it is administered intramuscular into the mid-thigh or the outer aspect of the upper arm. Most children should receive 4 doses, the first at 2 months, the second at 4 months, the third at 6 months, and the fourth between 12 and 15 months. Next, we have the varicella or chickenpox. So it is a common, highly contagious, and potentially serious disease of childhood. The causative organism is Varicella zoster virus, a member of the herpes virus group. So its vaccine is Varicella virus vaccine. It is composed of live, attenuated Varicella viruses. 2 subcutaneous products are available: Varicella vaccine by itself, sold as Varivax, and Varicella vaccine combined with MMR, sold as Proquat. For its efficacy, given as a 2-dose series, confers full protection in about 99% of vaccinated patients. For its adverse effects, it is very safe. No serious adverse events have been reported. Next is precautions and contraindications of varicella virus vaccine. It is contraindicated for pregnant patients, individuals with certain cancers, and individuals with hypersensitivity to neomycin or gelatin, both of which are in the vaccine. So, in addition, the vaccine should generally be avoided by individuals who are immunocompromised. For its route, site, and schedule of immunization, it is administered subcutaneous into the outer aspect of the upper arm or into the anterolateral thigh. All recipients should get 2 doses. Current recommendations are as follows. So for children who never had chickenpox, give the first dose between 12 to 15 months and the second dose between 4 to 6 years. For children aged 13 years or older who have not been vaccinated yet and not have had chickenpox, give 2 doses at least 28 days apart. Next is the hepatitis B. It is a serious liver infection caused by the hepatitis B virus. Acute infection can cause anorexia, malaise, diarrhea, vomiting, jaundice, pain in muscle joints and stomach, and death. For its efficacy for the hepatitis B vaccine, greater than 85% of vaccinated patients are protected after the second dose of Hep B, and more than 90% are protected after the third dose. For the adverse effects and contraindication, it is one of the safest vaccines. The most common reactions are soreness at the injection site and mild to moderate fever. Acetaminophen or ibuprofen may be used to relieve discomfort, but aspirin should be avoided. For the hepatitis A, it is a serious liver infection caused by the hepatitis A virus. For its vaccine, the preparation is prepared from inactivated Hep A virus. In the United States, 2 products are available: Havrix and Vacta. So efficacy, immunization with it, Hep A decreases with the risk of clinical disease by 94% to 100%. Protection appears to be long-lasting. Who should be vaccinated? Hepatitis A vaccination is recommended for all children 12 through 23 months old, and for children older than 23 months who live in areas where vaccination programs target older children. For its adverse effects, mild reactions are common. Soreness at the injection site occurs in about 54% of adults and 18% of children. So headache occurs 14% of adults and 9% of children. Other mild reactions include loss of appetite and malaise. When mild reaction occurs, they usually begin 3 to 5 days after vaccination and last only 1 to 2 days. For its route, site, and the schedule of immunization, Hep A vaccine should be given intramuscular into the deltoid muscle. 2 doses are required, given at least 6 months apart. The first can be given at 12 months. The second should be given 6 to 12 months after the first. For the next, pneumococcal infection, it is the leading bacterial cause of childhood meningitis, sepsis, pneumonia, and otitis media. Among children with pneumococcal meningitis, up to 50% suffer permanent brain damage or hearing loss, and about 10% die. The risk of acquiring pneumococcal infection is highest for children under the age of 2 years. For the vaccine, or the pneumococcal conjugate vaccine, there are 2 vaccines for pneumococcal disease: a 13-valent pneumococcal conjugate vaccine, sold as Prevnar 13, and an unconjugated pneumococcal polysaccharide vaccine, sold as Pneumovax 23. For adverse effects, it appears very safe. No serious adverse effects have been reported. About 50% of vaccinated patients get drowsy after the shot, lost their appetite, or develop erythema or tenderness at the injection site. About 33% develop localized swelling. Mild fever develops in 33%, and a higher fever develops in 5%. About 80% become irritable or fuzzy. Who should be vaccinated? It recommends vaccinating children in the following groups: all children younger than 2 years, all healthy children between their 2nd and 5th birthdays who have not completed the PCV series, and all children between their 2nd and 5th birthdays who have conditions that put them at high risk of serious pneumococcal diseases. Next is the meningococcal infection. It is a serious disease caused by Neisseria meningitis, also known as meningococcus. Invasive meningococcal disease is a leading cause of meningitis in American children. Efficacy of the vaccine. The efficacy of MCV4 at preventing meningococcal diseases has not been evaluated in clinical trials. However, we do know that vaccine is highly immunogenic. For example, when 423 adolescents were vaccinated, rates of seroconversion for serogroups A, C, Y, and W135 were 100%, 99%, 98%, and 99% respectively as measured by bactericidal antibody assay. For adverse effects, the most common reactions are local pain, headache, and fatigue. Local redness, swelling, and induration are also common. Concerns that MCV4 might cause Guillain-Barré syndrome appears to be unfounded as shown by 2 large studies. So should be vaccinated? The ACIP recommends routine MCV vaccination for all children and adolescents ages 11 through 18 years. Children who are not vaccinated at this time should be vaccinated as soon as possible. So how many doses? It should receive 2 doses, a primary dose and a booster dose. The recommendation is new. In the past, 1 dose was considered sufficient. However, we do know that protection does not last as long as previously believed, hence the need for a booster. So for its route and site, vaccination is done by intramuscular injection, preferably to the deltoid muscle of the upper arm. Next is the influenza. Influenza is a serious infection of the respiratory tract and a major cause of morbidity and mortality worldwide. Characteristics of the influenza virus and of influenza itself are discussed later on. So for influenza vaccines, it is recommended for all children between ages 6 months and 18 years. Properties of intradermal and intranasal influenza vaccines, along with information on adult vaccination, are presented later on. So for the rotavirus gastroenteritis, it infects the intestinal mucosa, is the most common diarrheal pathogen worldwide. Infection presents initially as upset stomach and vomiting, usually with fever, and then progresses to several days of diarrhea, which can be mild to severe. The combination of vomiting and severe diarrhea can result in life-threatening dehydration. For the rotavirus vaccine, preparation and efficacy, both contain 2 rotavirus vaccines are available, Rotatec and Rotarix. Both contain live attenuated viruses. To induce a strong immune response, this virus must replicate within the infant's gut. Accordingly, the vaccine is administered by mouth. Rotatec and Rotarix differ in composition and dosing schedule. For safety, although generally very safe, both Rotatec and Rotarix may carry a small risk of intussusception, a rare life threatening. So who should be vaccinated? All ACIP recommends that all infants receive rotavirus vaccine beginning around age 8 weeks. For the preparation route and immunization schedule, Rotatec is applied in single dose, 2 ml vials for oral dosing. For genital human papillomavirus infection, it is infection caused of virtually all anogenital warts and cervical cancers. Transmission occurs most often by direct genital contact during vaginal or anal intercourse. The types of HPV that infect the anogenital region can also cause cancers of the vulva, vagina, urethra, tongue, tonsil, penis, and anus. For the 2 HPV vaccines are available, Gardasil and Gardasil 9. Gardasil is a quadrivalent vaccine covering 4 types of HPV. Gardasil 9 was developed later and is a 9-valent vaccine protecting against 9 types of HPV. So for safety, it appears to be very safe. Injection site reactions, pain, erythema, swelling, and itching, although common, are mild and short-lived. So who should be vaccinated? Given that it is sexually transmitted and that HPV infects males and females, universal vaccination would be required to achieve maximal protection in the community. So for its route, site, and schedule, the HPV vaccine is injected intramuscular into the deltoid region of the upper arm or the thigh, anterolateral thigh. 3 doses are given over a 6-month interval. And for the respiratory syncytial virus, an enveloped virus of the Paramyxoviridae family was first identified in the 1956. Is the most common cause of bronchiolitis, an inflammation of small airways in the lungs, and pneumonia in children younger than 1 year, and the most common cause for hospitalization in children younger than 5 years. So for respiratory syncytial virus vaccine, or experimental, scientists are currently testing experimental vaccines to prevent RSV. In animal tests, an RSV vaccine elicited high levels of RSV-specific antibodies.
Now we are in the
Third part of our topic, we have the immunosuppressants. It is drugs that inhibit immune responses. They have two principal applications: the prevention of organ rejection in transplant recipients and treatment of autoimmune disorders. At the doses required to suppress the allograft rejection, almost all of these drugs are toxic. Two outcomes of toxicity are of particular concern: the increased risk for infection and the increased risk for neoplasms. For the calcineurin inhibitors, cyclosporine, tacrolimus, and primecrolimus are the most effective immunosuppressants available. Although these drugs differ in structure, they share the same mechanism. So for the cyclosporine, it is a powerful immunosuppressant and a drug of choice for the preventing organ rejection in recipients of an allogenic transplant. So for the tacrolimus, it also known as FK506, is an alternative to cyclosporine for preventing allograft rejection. The drug is somewhat more effective than cyclosporine but also more toxic. For the mTOR inhibitors, it is named so because they inhibit an enzyme known as mammalian target of rapamycin, or simply mTOR, a protein kinase that helps regulate cell growth, proliferation, and survival. The ultimate result is suppression of B-cell and T-cell proliferation. So for sirolimus, it is an immunosuppressant approved only for preventing rejection of renal transplants. The drug should be used in conjunction with cyclosporine and glucocorticoids. For everolimus, it is approved to prevent organ rejection in patients ages 18 years and older following a liver or kidney transplant. For the glucocorticoids, are used widely to suppress immune responses. Applications range from suppression of allograft rejection to treatment of asthma to therapy of autoimmune disorders such as rheumatoid arthritis, systemic lupus erythematosus, and multiple sclerosis. It also have multiple effects on elements of the immune system. They cause lysis of antigen-activated lymphocytes, suppression of lymphocyte proliferation, and sequestration of lymphocytes at extravascular locations. For the cytotoxic drugs, we have it is to suppress immune responses by killing B and T lymphocytes that are undergoing proliferation. First, we have the azathioprine. It is an immunosuppressant effect result from suppression of B and T lymphocytes secondary to interference with folate metabolism. Second is the cyclophosphamide. It is a prodrug that is converted to its active form by the liver. The active form is an alkylating agent that cross-links DNA, leading to cell injury and death. Next, for the cytotoxic drugs, is the methotrexate. It is developed as an anti-cancer agent, was later found to be effective in cirrhosis and arthritis and other autoimmune disorders. Next is mitoxantrone. It is developed to treat cancer and then used later for immunosuppression owing to its toxic effects on macrophages and B and T lymphocytes. As an immunosuppressant, mitoxantrone has only one indication: reduction of neurologic disability and clinical relapse in patients with multiple sclerosis. And lastly, we have the mycophenolate mofetil. It is approved for prophylaxis of organ rejection in patients receiving allogenic heart, liver, or kidney transplant. The drug should be combined by clocosporin and glucocorticoids. For the antibodies, we have the muromonab CD3. It is used to prevent acute rejection of kidney, heart, and liver transplants. In addition, the drug is given to deplete T cells from bone marrow before bone marrow transplantation. And next, we have the basiliximab. It has only one indication: prophylaxis of acute organ rejection following renal transplantation. The regimen should also include clocosporin and a glucocorticoid. Next is the anti-thymocyte globulin. Therapeutic effects result from a decrease in the number and activity of thymus-derived lymphocytes. Both anti-thymocyte globulin preparations are approved for preventing projection of renal transplants. And that's it for the third topic outline of immunosuppressants.
Antihistamine. Histamine is a small molecule produced in specialized cells throughout the body. The compound plays an important role in allergic reactions and regulation of gastric acid secretion. The antihistamine, a widely used family of drugs, block histamine action. There are two major classes of histamine receptors. We have H1 receptor and H2 receptor. The activation of H1 receptor causes vasodilation, increased capillary permeability, pain, itching, and bronchoconstriction, CNS effects. Activation of H2 receptor causes release of gastric acids from parietal cells of stomach. First generation antihistamines: brompheniramine, chlorpheniramine, climastatin, cyproheptadine, dechlorpheniramine, diphenhydramine, hydroxyzine, promethazine. Second generation antihistamines: cetirizine, desloratadine, fexofenadine, levocetirizine, and loratadine. For our therapeutic goal, oral therapy, relief of symptoms of mild to moderate allergic disorders. Example: allergic rhinitis, allergic conjunctivitis, uncomplicated urticaria, and angioedema. Parenteral therapy, treatment of allergic reactions to blood or plasma, adjunctive therapy of anaphylaxis. Identifying high-risk patient, antihistamine should be avoided during the third trimester of pregnancy and in nursing mothers and newborn infants. Exercise caution when treating young children, older adults, and patients with conditions that may aggravate by muscarinic blockade, including asthma, urinary retention, open-angle glaucoma, hypertension, and prostatic hypertrophy. So, administration routes: all H1 blockers used for systemic therapy can be given PO. Some can also be administered IM, IV, or rectal suppository. So, advice for the patient is to take oral antihistamines with food if GI upset occurs. Warn patients not to crush or chew enzymatic-coated preparation. Teach patients how to administer orally disintegrating tablets. Minimizing adverse effect. For sedation, most of patients a first-generation antihistamine in an alkali group can provide effective H1 receptors with only modest sedation. If sedation is excessive with alkaline, a second-generation antihistamine, example is fexofenadine, can be used. With long-acting antihistamine, a sedation can be minimized by administering a daily dose in the evening. Caution: patient to exercise with the caution when driving or doing other hazardous activities. Anticholinergic effects. Advise patient that dryness of the mouth and throat can be reduced by using a hard sugarless candy and taking frequent sips of liquid. Other atropine-like responses: urinary hesitancy, tachycardia, and constipation are not usually problems. Second-generation antihistamines have minimal anticholinergic effects. Gastrointestinal distress. Advise patient that GI disturbance, nausea, and vomiting can be minimized by taking antihistamines with meals. Effects in older adults. Older patients are especially sensitive to CNS and anticholinergic effects Be alert for CNS effects. Example, dizziness, incoordination, confusion, and fatigue. And exaggerated anticholinergic effects, dry mouth, urinary hesitancy, and constipation. Severe respiratory depression. Severe respiratory depression, promethazine can cause fetal respiratory depression, especially in very young. Do not give promethazine to children younger than 2 years old and use it with caution in children older than 2 years. So, severe tissue injury. Parenteral promethazine can cause severe local tissue injury. If an IV line becomes extravasitated or following inadvertent perivascular, intraarterial, or intraneuronal dosing. Gangner requiring amputation has developed accordingly when parenteral dosing is needed. The preferred route is IM. If IV dosing cannot be avoided, promethazine should be administered through a large bore, free-flowing line in concentration of 25 milligrams or less at the rate of 25 minutes or less. Advise patients to immediately report local burning or pain. For our adverse interactions, CNS depressant. CNS depressants, alcohol and other CNS depressants can intensify the depressant action of an H1 antagonist. Warn patient against drinking alcohol. Dosage of CNS depressants. Example is barbiturates, benzodiazepines, opioids may need to be reduced. Second generation antihistamine have minimal CNS depressant effects and hence are less likely to potentiate the action of CNS depressant. Cyclooxygenase inhibitors, non-steroidal anti-inflammatory drugs, and acetaminophen. Non-steroidal anti-inflammatory drugs. First generation niacids, aspirin, diclofenac, diflunisal, etodoctal, etodolac, phenophrine, fluorobiphrin, ibuprofen, salsalate, sodium salicylate, solindac, tolmentin, endomethacin, ketoprofen, ketorolac, magnesium salicylate, meclofenamate, mefenamic acid, meloxicam, nambuton, naproxen, oxaprozin, ferrocicam. Second generation niacids, celecoxib. Therapeutic goal, major indication for niacids are inflammatory disorders like example rheumatoid arthritis, osteoarthritis, mild to moderate, pain, fever, and primary dysmenorrhea. In addition, aspirin is used to prevent myocardial infarction and stroke. Administration routes: oral, all niacids; topical, diclofenac; patch, solution, and gel; intranasal, ketorolac; intramuscular, ketorolac; intravenous, ibuprofen and ketorolac; rectal suppository, aspirin and indomethacin. For advice for the patients to take oral niacids with food, milk, or a glass of water to reduce gastric upset. Warn patients not to crush or chew eccentric coated or sustained release formulations. Advise patient to discard aspirin preparation that smell like vinegar. Advise patient to use topical diclofenac to apply gel 4 times a day or to apply a new patch twice a day. Niacids frequently cause mild GI reactions, dyspepsia, abdominal pain, nausea. To minimize GI effects, advise patients to take niacids with food, milk, or water. Long-term therapy, even at moderate doses, can cause gastric ulceration, perforation, and hemorrhage. Glucocorticoids in non-endocrine disorders. Glucocorticoids: betamethasone, cortisone, dexamethasone, hydrocortisone, methylprednisolone, prednisolone, triamcinolone. Therapeutic goal: glucocorticoids are used to suppress rejection of organ transplant and to treat variety of inflammatory, allergic, and neoplastic disorders. When treating inflammatory and allergic disorders, the goal is to suppress signs and symptoms to the acceptable level, not to eliminate them. Identifying high-risk patient. Glucocorticoids are contraindicated for patients with systemic fungal infection and for individuals receiving live virus vaccine. Use glucocorticoids with caution in pediatric patients and in women who are pregnant or breastfeeding. In addition, exercise caution in patients with hypertension, open-angle glaucoma, heart failure, renal impairment, esophagitis, gastritis, and peptic ulcer disease, myasthenia gravis, diabetes mellitus, osteoporosis, and infections that are resistant to treatment, and in patients receiving potassium-depleting diuretics, dioxin, insulin, oral hypoglemics, or niacids. When these drugs are necessary, dosage adjustments may be glucocorticoids are administered orally, parenterally, IV, IM, sub-Q, topically, to skin or mucous membranes, intranasally, by inhalation and by injection, intraarticular. Dosage is determined empirically for patients whose disorder does not threaten life. Dosage should be low initially and then gradually increase until the desired response is achieved. For a life-threatening disorder, initial doses should be as large as needed to control symptoms. During prolonged activity therapy, the dose should be reduced to the smallest effective amount. Supplemental doses are needed at times of stress unless the dose is very high to begin with. Alternate day therapy. Alternate day dosing reduces adrenal suppression and other toxicities. Instruct patients to take their glucocorticoid medicine before 9 a.m. every other day. Drug withdrawal. Glucocorticoids taken chronically must be withdrawn gradually. Warn the patient against abrupt discontinuation of treatment after termination, and supplemental doses are needed during times of stress until adrenal function has recovered fully. Minimizing adverse effects. Pregnancy and lactation. Used in pregnancy and lactation, glucocorticoids can induce adrenal hypoplasia in developing fetus. When large doses had been employed, the newborn should be assessed for adrenal insufficiency and given replacement therapy if indicated. During high-dose therapy, the glucocorticoid content of breast milk may become high enough to affect the nursing infant. Warn women who are receiving high-dose therapy not to breastfeed. Minimizing adverse interaction. Insulin and hypoglycemics. Glucocorticoids can elevate blood levels of glucose. Diabetic patients may need to increase their dosage of insulin or other hypoglycemic drugs. Vaccines. Glucocorticoids can increase antibody responses to vaccines and can increase the risk of infection for live virus vaccine. Immunization should not be done while glucocorticoids are in use. So that's all for our report about anti-inflammatory, anti-allergic, and immunologic drugs. Thank you for watching this video.